और चड्डा जी आप मेरी इंट्रोडक्शन काफी शॉर्ट देना है।
डेफिनेटली सर, बिल्कुल जी।
और रिलेवेंट चीजें ही बोलना, अगर बहुत लंबा लंबा पब्लिक को बोल
नहीं बिल्कुल सर, बिल्कुल।
अब 32 टाइम तो हो गया, आप क्या है?
डोंट वरी सर। हाँ जी, हाँ।
गुड इवनिंग सर।
गुड इवनिंग। आप
गुड इवनिंग सर।
तो हमें मालूम पड़ जाता है कि 8 o'clock हुआ है। I match my watch once you enter. Yes, it is 8 o'clock. लक्ष्मी जी नमस्कार।
सर नमस्कार सर। नमस्कार सर।
बताइए बताइए। ठीक है, 5 मिनट बैठा दिया बात करिए। हमारे 10 मिनट में 5 से 25 कैसा रहेगा मुझे? 7 को 10 मिनट
Madam, good evening. Kalita, madam, good evening.
Yes, good evening. How are you?
Fine, madam. Thanks for joining us. And
Thank
we are going to
you.
listen.
Thank
We are going to
you.
listen. Learn neurophysiology. Learn neurophysiology from you, madam.
It's a interesting case, but not. It will be okay. We will talk each other and let's see. Enjoy the moment.
Yeah, hello,
Yes, madam. Thank you.
शायद मेरा करेक्ट कॉन्फ्रेंस है भारत को चलो सर्विस कितना है पहले दिन तो कॉन्फ्रेंस कर अच्छा हो ચાલો તો કોન્ફરન્સ ચાલુ થઈ ગઈ તમને 7:30 નો શાર્પ ટાઈમ હતો ને અત્યારે 8 વાગી ગયા છે સાહેબ પરિવારમાં ફ્રી થાય તો વાત કરીએ गिरीशભાઈ નામનો ભાઈ જોડે હશે એને કહો કે તમને સાહેબે 7 થી 7:30 નો ટાઈમ આપ્યો 8 વાગે તો સાહેબની કોન્ફરન્સ હોય ક્યાંથી વાત કરી છતાં એમની પણ તજવી હશે છતાં મને ફોન કરી દીધું हेलो
Sir, shall we start?
Yes, yes, sure.
Good evening, friends. I welcome you all for the 32nd episode of Secret of Neurology. As you all are aware, this is the longest web series till date, especially in the neurology segment. And we are very thankful to our course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir, those who have designed this web series in such a beautiful way, which will be very helpful to all the DM and DNB students. Today, we are having a team from the Sanjay Gandhi Postgraduate Institute of Lucknow. They will present their case, and it's honor and pleasure to introduce our course director, Dr. Sudhir Shah sir. Sir is a professor and head of department and NHL MMC and SVP MSR Ahmedabad. And sir is the director of neurosciences, Sterling Hospital, Ahmedabad. Sir is currently affiliated as a professor and HOD NHL MMC Ahmedabad and consultant neurologist to HE, the governor of Gujarat also. Sir has a lot of publications, also author of 6 books on neurology. And sir has achieved the most prestigious award, that is Padma Shri, in 2016. Sir has achieved Dr. B.C. Roy Award in 2018, and he is a recipient of UN Award also. Sir is having an interest in stroke, neurodegenerative diseases, and epilepsy. And further to this, it's honor to introduce our second course director, Dr. Lakshmi Narasimhan sir. Sir is director and professor, Institute of Neurology, Madras Medical College, Chennai. Sir is awarded with PALATUCCI advisor from AIN 2007 and A.B. Baker Award for Global Best Teacher of American Academy of Neurology and Best Paper Award of American Academy of Neurology and American Indian Neurology Association 2009. Sir has contributed a lot in the neurosciences, 3-term executive member in the Indian Academy of Neurology and CME convener, Indian Academy of Neurology, successfully organized 7 consecutive clinical neuroscience program for all the DM students, as the program name is SHINE. Not taking much of your time, I'm handing over this session to Sri sir to take this journey further. Over to you, sir.
Thank you. Thank you, Mr. Chadda. I welcome all the delegates and the speakers for today's wonderful session. As has been told, this is 32nd consecutive webinar on Pulse of Wisdom, Secrets of Neurology, one of the most favorite webinars for learning and teaching. This time we are honored of having one of the most prominent teams of academics, that is SDPGI team. Before that, I take the pleasure to thank Mr. Chadda and his team from the Global Cell INTAS division for the continuous logistic support. I also thank my co-course director, Dr. Lakshmi Narasimhan, without whose efforts this much achievement would not have been successful. I am also thankful to all the delegates for your continuous support, enthusiasm, and your feedbacks, which has made this webinar series very, very powerful. Today, as per our standard pattern, there will be case presentation. Case presentation will be from the SDPGI Lucknow. It will be done by Dr. R. Mahajan, the assistant doctor. Analysis of clinical history will be done by Dr. N. Babu, the assistant professor. Neurophysiology study will be done by discussed by Dr. S. Trivedi, the fellow. The analysis of investigation and management will be done by Dr. P.C. Pandey, again the assistant professor. Summary and conclusion will be done by no less a person but Professor Kalita herself. And may I have the slides, please? Next slide, please. Yeah. So Dr. Rupali Mahajan, as I told, will be presenting the case from the Department of Neurology. Dr. N. Babu is the assistant professor from the same institute. The Dr. S. Trivedi is fellow, electrophysiology department. That aspects of the case will be discussed by her. The assistant professor, Dr. P.C. Pandey from SDPGI, he will be discussing further analysis of the investigation. And next slide, please. I have pleasure of introducing Madam Dr. J. Kalita, Professor of Neurology. Everybody across India and abroad knows her very well, but it's my pleasure to introduce her adequately. She's a wonderful teacher, a great writer. She has more than 476 original publications to her credit, written 5 books, several book chapters. She has received several awards, including Best Neuroscientist Award in 2017, ICMR Award, Amrit Award, Fellowship. She has received prestigious fellowship of American Academy of Neurology, Indian Academy of Neurology. She has trained more than 100 DM students from SGPGI, Chandigarh. As you know, her area of interest and her contribution is profound in the area of infection, stroke, movement disorder, and so many other things in tropical neurology. Her original articles on Japanese encephalitis, dengue, scrub typhus, tubercular meningitis, stroke, migraine, nutritional deficiency, Wilson disease, etc., are very, very highly quoted. She has got faculty-based research in neuroscience in India during 2015-17, and she has done scientometric analysis, second most impactful author in India. That is, so it's a matter of a great pride and privilege to have her today with us for our continuous education series. And as I mentioned, she has so many other accolades. So I welcome you, ma'am. And with that, I once again thank all the delegates and all previous speakers and my course director, co-course director, as well as team in task for all this continuous support and kind of feedbacks. Thank you very much. And madam, I request you to handle the session from now, this moment
Okay,
onwards.
thank you, sir. Thank you very much. The case, I now request Dr. Rupali to present the case.
Good evening, worthy.
Okay.
Good evening, worthy teachers, respected seniors, and my colleagues. Myself, Dr. Rupali Mahajan, Senior Resident, Department of Neurology, SGPGI, Lucknow. Today, we'll be presenting an interesting case from our department. Let us begin. 16 years old female, resident of Kanpur, student of 11th class, presented with complaints of fever for 7 days, lasted for 4 days, quadriparesis for 2 days, urinary retention for 2 days. Fever was high grade to begin with, continuous in nature, associated with malaise and mild headache. There were no associated rigors and chills. Fever got relieved with paracetamol and subsided after 4 days. 2 days, for 2 days, patient remained asymptomatic and afebrile. Further, after 2 days, she developed sudden onset, severe tight band-like lower back and neck pain, lasted for 1 hour, followed by quadriparesis, started in the bilateral lower limbs, affected both proximal and distal muscles simultaneously, and progressed over the next 2 hours, involved upper limbs also. So for the next 4 hours, she became bedridden and there is associated history of urinary retention. Patient was not able to perceive any sensations below her neck, though there is no history of headache, seizures, loss of consciousness, decreased vision, double vision, facial asymmetry, change of voice, difficulty in swallowing, breathing, vomiting, or hiccups. There is no history of preceding abdominal pain, diarrhea, multiple joint pain, rashes, and bleeding tendencies. Also, there is no history of recent vaccinations and dog bite. In past history, she was having no history of similar complaints in the past. In her personal history, she is vegetarian by diet but consumes milk, no known addictions, with normal bladder, bowel, and sleep habits before the illness. Family history is not significant. Regarding her socioeconomic and environmental history, she belongs to a lower middle class family, lives in a pakka house, consumes tap water, and in nearby locality, there are many stagnant water bodies. So with this history, she was immediately rushed to the nearby hospital where she was admitted. And on day 2nd of her hospitalization, she developed hypertension and bradycardia. And she was intubated, as the ABG shows hypoxemia and hypercarbia. Sorry, we are not having that ABG along with us, but ABG was showing hypoxemia and hypercarbia. And she was started on noradrenaline infusion at the rate of 4 ml per hour, 640 microgram per hour. That means near about 10 micrograms per minute. And also she was on methylprednisolone infusion at the rate of 2 ml per hour infusion. And with all this, she was referred to SGPGI. And this is the ECG that was done in the peripheral hospital. And here we can see ECG's sinus showing heart rate of 51 per minute with normal P wave and T wave morphologies, with PR interval less than 0.12 and QT interval nearly about 370 seconds. So inference is sinus bradycardia. So this is the it's 370 milliseconds. This is the temporal line. Patient was having fever, lasted for 4 days. 2 days later, she developed quadriparesis along with urinary retention. And the next very day, she developed bradycardia and hypotension. And she was intubated and started on inotropic support and methylprednisolone infusion. So on receiving her at SGPGI emergency, patient was afebrile, documented temperature was 98.8 degree Fahrenheit, pulse rate was 64 per minute, saturation, she was on ambu ventilation, and at that time saturation was 95%. Her BP was 8254 millimeter of mercury on noradrenaline and methylprednisolone infusion. She was alert, awake, and looking here and there, and she was having pallor, but no icterus, cyanosis, clubbing, edema, or lymphadenopathy. Skin was not cold or clammy. Skin was normal to touch. There were bilateral conducted sounds heard in the infraxillary and infrascapular area. And in cardiovascular examination, no added sounds were heard. And there was bradycardia. Pulse, per abdomen examination revealed mild distension, but that was tympanic on percussion. Coming to the neurological examination, she was conscious, cooperative, and oriented, and she was communicating by blinking and eye communication. In cranial nerve examination, pupils were normal in size, shape, and direction. Fundus was normal, and there is no restriction of any extraocular movements. Cranial nerve 5th and 7th were also normal. Their reflex and pharyngeal sensations were normal, but she was not able to shrug her shoulders. There was no tongue atrophy or deviation. In motor examination, there was areflexic quadriplegia of grade 0 with bilateral hypotonic quadriplegia of grade 0 with bilateral mute plantars. Coming to the sensory examination, she was unable to perceive sensation for touch, pain, and temperature below the C2 level. Vibration she could perceive on occiput only. There was no nystagmus and no neck rigidity. Back and spine revealed no tenderness or bony deformities. Rest autonomic detailed testing couldn't be done in view of marked bradycardia, hypertension, and she was on noradrenaline support. Even slightest of the neck movement and change in the position was resulted into decrease in heart rate and severe cardiovascular instability. So with this, I request Dr. Nagendra sir to carry the discussion further. Thank you.
Thank you, Dr. Rupali. And good evening, everyone. Now, I'll be talking about the symptom analysis and localization. We have a young girl who presented to us with symptom complex of flaccid areflexic sensory motor quadriparesis, urinary retention, respiratory failure, bradycardia and hypotension with preceding history of self-remitting fever. Now, her first symptom is fever. Fever could be due to infection or inflammation or any underlying malignancy. However, given the very short history of fever, the inflammatory and malignant causes are less likely. Now, the fever is high grade, associated with severe malaise, and remitted within 4 days. So this suggests that the fever could be likely viral. She had sensory motor flaccid areflexic quadriparesis. This could be due to transverse myelitis in spinal shock. The points favoring this cause are presence of definite sensory level, early bladder involvement, and neck pain and gutty-like sensation. Other cause of such symptomatology can be either epidural abscess with compressive myelopathy. Points favoring are
Okay, hello, तुमको बता दो that my slides are.
Are my slides visible?
Yes, it is visible, but if you can, put it in a slideshow mode.
Slideshow mode करो. Slideshow mode.
1 second.
Slideshow. नीचे से नीचे.
Yes.
Close limit. Is it moving? Okay. Okay.
So I have discussed about her symptomatology of fever. Her sensory motor flaccid areflexic quadriparesis. First cause, likely cause is transverse myelitis in spinal shock. We have discussed the points in favoring this cause. The second cause is epidural abscess with compressive myelopathy. Points favoring this cause are presence of fever and severe neck pain. However, spontaneously remitting fever and absence of any neck or spinal tenderness or any systemic infection and absence of retropharyngeal abscess goes against this cause. Now, this symptomatology can also be due to fulminant Guillain-Barré syndrome. Points favoring are presence of ascending type of weakness, areflexia, and dysautonomia early in the course of illness. However, presence of definite sensory level and early bladder involvement goes against the Guillain-Barré syndrome. Although bladder involvement can be seen in Guillain-Barré syndrome, it is transient and later in the course of illness. With the presence of history of fever and myalgias, a possibility of viral myositis can be kept. However, presence of sensory symptoms, bladder involvement, and absence of any muscle tenderness goes against the etiology of positive factor of viral myositis. So with considering all the possibilities, transverse myelitis in spinal shock looks to be the likely cause. The next symptom is urinary retention. This can be due to the transverse myelitis because it is bladder involvement is an integral part of acute transverse myelitis. It is caused because of the interruption of the neuraxis, causing the disruption of ascending and descending signals to the bladder. However, transient bladder dysfunction can also be seen in Guillain-Barré syndrome as a part of autonomic dysfunction because of sympathetic overactivity. Coming to respiratory failure, she has a hypoxic hypercarbic respiratory failure, which can be due to diaphragmatic palsy, probably due to the lesion involving the cervical spinal cord involving the segments C3, C4, C5. Or it can be due to the phrenic nerve demyelination as a part of Guillain-Barré syndrome. Another possibility that can be considered is myocarditis with heart failure because viral infections, if they involve the muscle, can also involve the cardiac muscle in the form of myocarditis, finally landing up with heart failure. However, she has hypercarbic heart failure. In myocarditis, we expect a ARDS kind of picture, which is hypoxic heart failure. The other, further in the course of illness, she developed severe hypertension and bradycardia. Now the causes can be the presence of neurogenic shock in case of cervical spine injuries. This occurs due to the imbalance between sympathetic and parasympathetic activity. The sympathetic hypoactivity associated with parasympathetic hyperactivity can cause such type of clinical picture. This is also evident by the history that whenever her neck was manipulated, she used to have severe bradycardia and hypotension. This could be due to the pressure over the neck, the carotid bodies, leading to the parasympathetic overactivity. Another consideration that needs to be taken is myocarditis with cardiogenic shock. However, we expect tachycardia in case of myocarditis. But later in the course, in severe cases, the cardiogenic shock might land up with bradycardia in the late stages. However, in such a case also, we expect cold peripheries due to the vasoconstriction because of sympathetic overactivity, which is not there in this case. Another possibility to be considered is hypovolemic shock. In severe cases of hypovolemia, we expect postural hypotension, which we saw in this patient when we examined her. But however, in hypovolemic shock, we expect tachycardia with cold extremities, which are not there in this patient. In late stages, bradycardia plus hypotension can occur, but there are no clinical signs of hypovolemia also in this patient. Now, before going to the localization of the symptoms, just a brief note about the anatomy of the spinal cord and sympathetic autonomic nervous system. As we all know that the spinal cord is a cylindrical structure that extends from the foramen magnum to the lower end of the L1. In the early embryonic course, the spinal cord extends whole of the vertebral column, but during the development of the fetus, due to the differential growth, the lower level of the spinal cord ascends up to the lumbar vertebrae. The level, the adult level, that is the lower level at the end of L1 is achieved by the 3 months of postnatal life. Now, this is the transverse section of the spinal cord, which shows that the central spinal canal surrounded by a small area of the gray matter, which is in H shape. This has got the posterior horns, which contains the sensory neurons, the fibers from the sensory nerve. There is a small, which is not too obvious in this picture, but there is a small intermediolateral gray matter area, which is expected in the thoracic and lumbar cords, and the ventral enlarged area containing the motor axons of the motor axons. Surrounding this gray matter is the white matter containing the ascending and descending tracts. The major tracts, ascending tracts, are the posterior columns, and the spinothalamic tracts in the lateral and anterior column. The major descending fibers of the pyramidal tracts and the corticospinal tract, and also we have other tracts like rubrospinal and reticulospinal tracts. As can be seen in this picture, the thoracic segments have an extra enlargement in the intermediolateral region between the gray and between the dorsal and ventral horns, which contains the autonomic preganglionic cell bodies of the autonomic nervous system, that is sympathetic nervous system. This is the diagrammatic representation of the sympathetic nervous system. The autonomic control starts from the cerebral cortex at the level of frontal lobe and insular cortex, coming down to the hypothalamus, and from there the descending sympathetic fibers descend till the thoracic spinal cord, where in the intermediolateral horn, the preganglionic fibers, which are myelinated, exit the spinal cord and form the paravertebral sympathetic chain, and they extend from the superior cervical ganglion to the lower down up to the sacral area, from where the postganglionic sympathetic fibers do come and form the various ganglion that supply the various organs. The main consideration at this point is the presence of the from the T1 segment to the T4 segment, they form the cardiac plexus, which supply the cardiovascular system. Below the level, they form the cilia ganglion and the mesenteric ganglia, which supply the splanchnic vasculature. This is the picture showing the parasympathetic system. Parasympathetic system, also known as the craniosacral autonomic nervous system, because the fibers come from the cranial nerve nuclei and the lower sacral segments. The cranial nerves supplying, contributing to the parasympathetic nervous system are from the 3rd, 7th, 9th, and 10th through various ganglia. 3rd, 7th, and 9th nerves through various ganglia supply the lacrimal glands and the salivary glands. The most important is the vagus nerve. From the dorsal vagus nucleus, the parasympathetic fibers descend down and supply the bronchial tree, the lungs, the cardiovascular system, and through various ganglia, they also supply the gut system. And the sacral fibers supply the urinary bladder. If we can observe that the vagus nerve escapes the spinal cord in this, as evident in this picture. This is very important for our further discussion. With this background knowledge, coming to the localization, she has normal sensorium and no seizures and no other features of encephalopathy. There are no extrapyramidal symptoms or signs, and there is no nystagmus. Cranial nerves are normal except for weakness of the spinal accessory nerve. This localizes our lesion that the cerebrum, cerebellum, and the brainstem are intact, localizing the lesion below the foramen magnum, above the cervical spinal cord. The other symptom is the urinary retention. Pontine micturition center facilitates the urinary symptom of micturition, but a lesion in the pons can also cause the urinary retention. However, we don't have any other signs indicating the pons lesion. So the lesion is expected to be below the pons. The presence of sensory level below second cervical vertebrae and flaccid areflexic quadriparesis without any cranial nerve involvement except for the 11th nerve indicates that the motor level also contributes, corresponds to the upper cervical cord. And the presence of hypoxic hypercarbic respiratory failure indicating the diaphragm weakness also indicates that the level of the lesion could contribute to the upper cervical spinal cord, that is at or below the second cervical spinal cord level. Now coming to the autonomic dysfunction, as already discussed and evident from this picture, the presence of the vagus nerve escapes the spinal cord, and the sympathetic nervous system is an integral part of the spinal cord. So because there is a sympathetic dysfunction associated with parasympathetic overactivity, we expect the lesion to be below the brainstem and above the cervical cord. Also, sympathetic underactivity, there was no Horner syndrome. That is, the lesion is expected, we expect the lesion to skip the superior cervical ganglion. However, cardiac dysfunction in the form of disruption of the cardiac plexus is evident. This localizes the lesion to T2 to T4, T5 thoracic spinal segments. So after combining all these factors, we localize the lesion to the cervicodorsal spinal cord, evident as acute transverse myelitis. Coming to the etiological considerations, because of history of preceding fever, possibilities of infectious and para-infectious causes are kept as the prime first possibility. The causes can be either viral or bacterial. Mycobacterial and fungal or parasitic causes are less likely because of the very short history of illness. Among the viruses, herpes group and flaviviridae group are known to cause the acute transverse myelitis. Enterovirus group are involved in the acute, the anterior horn cells, creating a acute poliomyelitis kind of picture. Because of long segment spinal cord involvement, possibilities of demyelinating lesions were also kept, like neuromyelitis optica spectrum disorder, MOG antibody disease, or first episode of multiple sclerosis. However, the progression of symptoms in our case is around 4 to 6 hours, where in demyelinating lesions, we expect the lesion to be, the symptoms to be evolving over at least 24 hours of time. So this also keeps the demyelinating causes less likely. Another cause can be vascular etiology. Given the rapid, very acute onset of symptoms, vascular etiology is also kept as a possibility. However, the lesion is involving the whole of the spinal cord. So the spinal artery thrombosis or other etiologies are at a lower end. Hemorrhagic myelitis and AV fistulas needs to be considered, which are also kept as possibilities. So with this clinical localization, she was subjected to further investigations. At the initial hospital where she attended, she underwent certain investigations. The initial investigation showed that her hemoglobin is 13.6 and total leukocyte count is 10,600, which is in the normal range. And also rest of the biochemical parameters are in the normal range. Her chest X-ray on day 2 of illness showed when she was intubated because of the respiratory failure, showed that there is a small area of consolidation in the lower lobe of the right lung, also associated elevation of the right lobe of the diaphragm, probably eventuation of the diaphragm, or it can be due to the collapse consolidation of the right lobe of the lung. At this stage, she was intubated, and this is the ECG at the baseline, which is showing sinus bradycardia. The closer picture, we can see that the RR interval is around 101.16 seconds and corresponding to the heart rate of around 51 beats per minute. The PR interval is 100 milliseconds and the QTC is 371 milliseconds, which suggests that the bradycardia is not due to the intrinsic cardiac abnormality, conduction abnormality. Also, there is, if you can observe, there is no sinus arrhythmia, indicating that being a young female, we expect sinus arrhythmia. This absence of sinus arrhythmia suggests that there is some form of autonomic dysfunction. Also, she underwent CSF cerebrospinal fluid analysis on the day 3 of illness at the outside hospital, where the CSF showed that the total leukocyte count was 1,000 cells per cubic millimeter. The differential count showed that she is having neutrophilic predominance. The protein, CSF protein was 76 milligram per deciliter, which is elevated. The the CSF glucose was 54 milligrams per deciliter. Corresponding blood glucose was 92 milligrams per deciliter. This shows that there is no acute consumption of the glucose by the leukocytes, suggesting that the presence of these 1,000 cells is not due to pyogenic infection. Also, if we can see that the there is no peripheral leukocytosis, indicating that the causes of pyogenic etiology is less likely. After these are the investigations when she arrived at the SGPGA, where her total leukocyte count was showing 22,500 cells, showing the neutrophilic predominance. Rest of the biochemical parameters are normal. These 22,500 counts might indicate that she had secondary infection, probably because of either UTI or ventilator-associated pneumonia or acquired infection, likely to be hospital-acquired infection. So we have repeated her chest X-ray, which showed that there is complete opacification in the involving the entire of the right side of the lung, probably ventilator-associated pneumonia. Also in the midline, we can see that she is having the endotracheal tube in situ. The next X-ray is after she was started on antibiotics for few days and performing the chest percussion and regular physiotherapy, which shows that her lung is expanded, but there is a thin band of fibrosis in the below the upper lobe, suggesting that infection is still remnant. So this is the ECG in SGPGA while she was on noradrenaline support, which is showing that the RR interval is 880 milliseconds, and the corresponding heart rate is around 68 beats per minute. We have to note that this heart rate is on noradrenaline infusion. Whenever we try to taper of the noradrenaline, she used to have bradycardia in the initial part of the illness. The PR interval was 100 milliseconds and QTC was 341 milliseconds, which are normal. Also evident in this ECG is that there is no variation with the phase of the respiration. This is the ECG after she could be weaned of the noradrenaline after few days of treatment, which shows that the initial part of the ECG is showing a little longer RR interval, and the latter part of the ECG is showing the shorter RR interval. This is corresponding to the phase of the respiration, which suggests that she has acquired the sinus arrhythmia after some form of treatment. After these initial investigations, she underwent spinal MRI. This was the initial MRI spine at the outside hospital, which shows the T2 hyperintensities involving the whole majority of the cord, starting from the lower cervical segments to extending up to the conus medullaris. We have repeated the MRI at SGPGI because we also wanted to get the MRI brain. So simultaneously we got the spinal MRI and brain MRI. This is the spinal MRI at the cervical spine. The T2 sagittal section showing that there are variegated hyperintensities extending from the lower end of the medulla, extending up to the whole of the cervical spinal cord. In the T1 sequence, with these hyperintensities in the T2 sequence, we expect that there should be some form of hypointensity. However, if we can closely observe that there are certain amount of hyperintensities which could suggest that there can be possibility of hemorrhagic myelitis. However, there is no obvious hyperintensities, but possibilities should be kept in mind. Also, we can see that there is swelling of the cervical cord. The last picture is showing that there is patchy contrast enhancement in the lesion, indicating that it is inflammatory in nature. This is the axial section of the cervical spinal cord. The initial T2 weighted image. The closer picture shows that the hyperintensity is involving the whole of the transection of the cervical spinal cord, indicating that it is acute transverse myelitis, hollow cord involvement. The second picture is showing the T1 contrast image. The closer section showing that there is patchy hyperintensities. Also, these similar hyperintensities can be seen in the dorsal spinal cord. The cranial MRI, T2 axial section showing that the brain basal ganglia and the midbrain and the pons lesion are normal. There are no abnormal signal intensities in the optic nerves and the optic chiasma. The next sequences showing that the pons upper medulla are normal. However, there are subtle hyperintensities seen in the lower medulla. The FLAIR image showing that that there is no abnormal signal hyperintensities. The T1 contrast image of the brain is also showing no abnormal lesions. SWAN sequence also is normal. The diffusion weighted image showing small amount of diffusion restriction in the lower medulla. Because we wanted to further evaluate the other causes of this transverse myelitis, we got her CSF repeated on day 5 when she arrived the SGPGI, which showed that the total leukocyte count has reduced to 500 cells. Still there is neutrophils. However, the lymphocyte predominance started to appear. The protein is elevated. She is further subjected to the microbiological investigation. The blood and urine culture were negative. Tracheal aspirate was sterile. Viral markers were negative. Further, CSF was sent for neurotropic viruses, which the report of which is awaited. Although there is least likely possibility of demyelinating disorder, because of the para-infectious nature, we have sent the acoparin 4 and MOG antibody, which came out to be negative. Initially, we had kept the possibility of myocarditis, so the serum cardiac biomarkers were sent in the form of CK and CKMB. Troponin were normal. 2D-echo was also normal. Other investigations included low vitamin B12 levels and vitamin D levels. However, vitamin B12 in this context is not significant because B12 deficiency is expected to cause subacute nature of symptoms. Vasculitis markers are negative. Then she was subjected to neurophysiological studies. This will be dealt by our fellow in neurophysiology, Dr. Sweety Trivedi.
Good evening, everyone. So this young female, 16-year, was sent to neurophysiology lab because she was having acute transverse myelitis, hollow cord involvement, and areflexic quadriparesis. So neurophysiology study was planned to assess her anterior horn cell involvement, whether and the extent of white and gray matter involvement in the spinal cord. So we planned the study. This had a hollow cord involvement to assess the gray matter, to assess the peripheral nerves and the gray matter. EMG and NCS was planned to assess the white matter pathways. Motor and evoked potential was planned. Sensory evoked potential for the posterior column and motor evoked potential for the motor pathways. So proceeding to the nerve conduction study, this was the nerve conduction study of this young female. The motor nerve conduction in a left median nerve, left annulum, and left common peroneal nerve was inexcitable. The sensory nerve conduction study in her left median, left ulnar, and left sural nerves showed that there were normal latency, amplitude, and velocity. This was the EMG of the patient. The biceps showed, most of the muscles showed fibrillation potentials and white positive sharp waves. There were florid denervation changes. This and in deltoid. Similar finding was present in vastus lateralis and also in tibialis anterior. Both upper limbs and lower limb florid denervation changes could be visible. Coming to the evoked potentials, motor evoked potential could not be done as the motor nerves were inexcitable. The sensory evoked potential showed median nerve had normal N9 latency, but the middle latency and distal longer latencies like N19 and P22 were not recordable. Thus, Erb's point latency was present. In tibial SSEP, N19 latency at the lumbar root entry zone was present, but P40 could not be recorded. To summarize, so we had a 16-year female with acute transverse myelitis and hollow cord involvement. The extent of gray matter could be said that it had anterior horn cell involvement in view of non-recordable motor conduction responses and normal sensory responses with florid denervation changes in the tested muscles of both upper and lower limb. The tibial and median SSCP, we could localize that the posterior column was involved proximal to the lumbar root entry zone and beyond the cervical cord, but upper limit of the proximal lesion cannot be delineated with this study. Thus, we could conclude only that anterior horn cell was involved in view of denervation changes and posterior column involvement was present. The next part of the presentation will be dealt by Dr. Rupali. Management part.
Before time तुम्हारा भी है ना मोबाइल चल रहा है नहीं मेरे को नहीं चाहिए मैं जल्दी तो हो गया क्या हो गया क्या क्या करते रहते जाए तब से बोलिए
So after the symptom analysis, localization and the neurophysiological study, let us come to the treatment and the course in the hospital part. As patient was having respiratory failure, for that we have kept the patient on mechanical ventilator on SIMV mode with pressure support. Initially, the supports were high. We have given from 24 to 20 pressure supports. For hypotension and bradycardia, patient was continued with the noradrenaline infusion. Initial days, we have difficulty in tapering the dose down, but later on, we could able to decrease our noradrenaline dosing a little lower over the next 6 days. For myelitis part, as she was on methylprednisolone infusion from outside, we have stopped the methylprednisolone infusion and we have given injectable methylprednisolone 500 milligram for 5 days, IV followed by oral to consider his her hypotension and bradycardia part also. For infection, collapse consolidation, likely VAP, patient was managed with antibiotics, ceftriaxone and doxycycline. That were continued for 10 days. Later on, shifted on to the oral levofloxacin. For nutritional support, we have given her RT feeding. And as the Dr. Nagendra has already discussed, vitamin B12 and vitamin D were on lower sides. We have managed her with injectable vitamin B12 as well as oral supplements with vitamin D. Later on, injectable vitamin B12 after 7 doses shifted again to the oral ones. Then the other symptomatic treatment were continued in the form of IV fluids and correction of these electrolytes. So this is the day 1 to day initial 10 days vital trend when the patient was on noradrenaline infusion and methylprednisolone injectable was given. This solid gray line is depicting systolic blood pressure. Solid orange line is depicting pulse rate. Yellow one diastolic BP and dark blue line pressure supports. And this is the lighter blue line. The lowermost lighter blue line is showing the doses of noradrenaline. So we can clearly see in the initial days, there is a bradycardia 42 and 56 heart rate was there, despite on the higher range of noradrenaline support. And we try to decrease the noradrenaline support and we can't continue to give the noradrenaline for longer days. So initial days we could titrate down it very slowly. And at that time, we have difficulty in managing her because in the night hours, she had extreme bradycardia to the extent that the heart rate dropped down to 40 to 38 even. At 2 to 3 occasions, he needed atropine injections also. But due course of time, over the next 4 to 5 days, we could able to decrease the noradrenaline dose and also pressure supports from initially 24, then 20, then 18. And her heart rate also start rising in the range of 64 to 62 and the maximum was 68. With on day 8th, when the noradrenaline dose we are giving at the rate of 0.8 ml per hour, pressure supports were 18, heart rate was 68 and but systolic BP was 92. At this dose, we consider stopping the noradrenaline because 90-60 BP is okay for her because she is thin built and weight is about 40 kg only. So over the next 10 days, we could able to stop the inotropic support and we have shifted the IV steroid on oral steroids. The next 1 to 2 weeks, she remained stable with BP minimum 84 systolic and maximum she could attain up to 100 also. So we could not able to do the autonomic testing in the initial days because of the severe bradycardia and hypotension. But at day 20, when the BP was in the higher range and without inotropic support, and at that time baseline heart rate was 70 beats per minute. BP was 158 millimeter of mercury. And on subsequent head raising 30 degree, 45 degree and 60 degree elevation, heart rate, there is only little increase in heart rate on postural change, 80, 78 and 94 respectively. But beyond 60 degree, she was feeling giddy and 1 episode of visual blurring and syncope also. So we could not subjected her to further elevations. At that time, BP at 1 minute and 3 minutes was also checked. BP as supine was 100 by 58 millimeter of mercury, but BP at 1 minute was 80-48 millimeter mercury, but at 3 minutes, 82-42 millimeter of mercury. So she could not attain even the proper tachycardia and systolic BP. And we have performed cold immersion test by putting her right hand in the ice cold water for about 3 minutes. Even then, she would not able to sustain her BP, and BP remain in the range of 96 by 56 millimeter of mercury. There is no further increase in diastolic or systolic BP. However, heart rate variability and Valsalva testing couldn't be done because she was unable to hold the breath, and whenever we try to give her artificial rate of 6 breaths per minute on ventilator, she was feeling air hunger, and we could not able to perform that. So with due course, after 20 days, there occur increase in her tracheal secretions, and we suspected hospital acquired infection and pneumonia and worsening of the pre-existing VAB. There was leukocytosis, that is the initial count were 22,000, but after 7 days counts were 7,000 and 8,000 when we have shifted her on levofloxacin. But in the later course of the hospitalization, count started rising again with increase in tracheal secretion, though X-ray was normal, and tracheal aspiration culture report came out to be positive for Pseudomonas aeruginosa. Also, same time, patient was having diarrheal illness, and frequency was 4 to 5 times small volume. That was non-bloody diarrhea and not associated with passage of mucus. As patient was hospitalized and received antibiotics, we considered the possibility of hospital-acquired Clostridium difficile infection also, but stool routine examination came out to be negative, and toxin test for Clostridium difficile was also negative. Ultrasound abdomen revealed no abnormality. And in her urinary catheter, there is turbidity in her urine. Other possibility for infection was kept UTI, though urine routine revealed 1 to 2 pus cells per high power field, and culture came sterile for urine as well as blood. So for respiratory parameters, we have continued SIMV support, but patient respiratory parameters are improving, and we could able to reduce her pressure supports from 20 to 12. And now patient could generate tidal volume of around 200 ml at zero support even. For infections, we have added antibiotics. We have actually stepped up the antibiotics. And right now she is receiving injection of Micacine, 500 milligram. And for others, nutrition, physiotherapy, and symptomatic treatment, we continued. And also considering the diarrhea and this increase in tracheal secretions, we added glycopyrrolate also to take about this cholinergic part. So at 30 days, yesterday only, we performed autonomic testing again. Now the pulse rate is 74 per minute, BP is 100 to 62 millimeter of mercury, and there is improvement because patient, even after elevation to beyond 90 degrees, she has no autonomic syncope-like symptoms. And BP also, initially there was significant drop of 20 systolic. Now there is a minimal drop of only 4, 96, 58, more or less in the same range only. Though cold immersion test was again negative, because BP was only 104 and 64 millimeter of mercury, and pulse rate was nearly in the same range. Again, heart rate variability and Valsalva we couldn't perform because patient is right now on this mechanical ventilation only. So these are the vitals of today. Patient is afebrile, documented temperature is 98 degree Fahrenheit, pulse rate 74, BP 100 by 66 without any inotropic support, mechanical ventilation, CPAP more, pressure support 12, and at zero support, she's generating tidal volume of near about 200. That is a good sign. Regarding neurological examination, she is more or less the same. Power is 0. Tone is not there. Reflexes are absent. But but she can elevate her neck, and there is slight power in. Patient can do shrugging of shoulder, though not against gravity. There is sensory improvement also, but only slight. So we are very hopeful that in the coming weeks, we could be able to wean her off from the ventilator, as there is always a light at the end of tunnel. With this message, I request Dr. Prakash sir to take over and continue the discussion further. Thank you.
First, whatever, current payment. Nine, moderate.
Now, we are present. What is the diagnosis at this juncture? For para-infectiology, viral markers available in our institute like herpes simplex, zoster, Epstein-Barr virus, CMV, paravirus, adenovirus, SENT, but all are found to be negative. Then we thought that there is any other para-infectious disease that we have to look that. Because of our previous experience, we sent as a Malaria for West Nile, and it was turned out to be positive. So then probably we are dealing with a case of acute transformalitis with severe cardiovascular instability. Here, above and all, retention of urine and constipation. See, it had bradycardia and hypertension. West Nile virus, couple of words about West Nile virus. West Nile virus belongs to family of Flaviviridae, producing central nervous diseases like Japanese encephalitis. The transmission cycle revolves mostly in between birds and mosquito. And when human being came into the contact of the mosquito, then it could be the human being become incidental host. When we retrospectively asked about her residential issues, the nearby her house there was some stagnant water and some birds were there. This is geographical distribution of neurotrophic viruses. The related neurotrophic flaviviruses found throughout the globe. The St. Louis virus in South and North America, West Nile virus in North America, Africa, Middle East, and Australia. The Japanese encephalitis in Japan, India. The Marburg virus in Australia. The spectrum of disease, the West Nile virus spectrum, around 60 to 80% patients remain asymptomatic. 20 to 40% patients shows viral illness-like illness, just like viral fever-like illness. Only 0.4% of patients became showing neurological symptom like meningitis, headache, meningeal signs, photophobia. They also showing meso features of encephalitis in form of tremor, myoclonus, extrapyramidal features, and cognitive disturbances, and acute flaccid paralysis. The acute flaccid paralysis, which usually rapidly develops within 48 hours, with or without meningeal signs. This is the usual course of any acute flaccid paralysis, acute transverse patients. 1/3 patients usually improves. 1/3 patients showing moderate disability, but 1/3 patient fails to improve, remain quadriplegic with respiratory failure. Now the few questions were remain unsolved. Can West Nile infection lead to myelitis without encephalitis? Can West Nile myelitis have hypotension and bradycardia? If it is so, then what is the mechanism of bradycardia and hypertension in West Nile myelitis? We search in PubMed. Is West Nile myelitis can be without encephalitis? Around 1/4 of the patient could show only myelitis. Another question, when search in PubMed, West Nile myelitis, hypertension, bradycardia, we didn't get any literature. But on searching acute myelitis with bradycardia, we got 4 cases. The detail of these 4 cases are as such. This is the case of the 3-year-old girl. For myelitis, she receives MPS, IVIG, plasmapheresis. For bradycardia, it was so severe that she needs a permanent pacemaker implantation. Final outcome of this patient, she remained bedridden and but with normal cognitive. This is again it's a case of autonomic dysreflexia following acute myelitis due to neuromyelitis optica. The patient received my MPS and plasmapheresis for myelitis treatment, and for episodes are available, but pressure and sinus bradycardia, she needs no intervention. Patient became completely recovers completely in a couple of weeks. This is a case report of cardiovascular impairment in patient with acute myelitis. For myelitis prospect series, a patient received MPS. For sinus bradycardia, SOS atropine followed by dopamine infusion needed, and this patient also recovers completely. This is also a case of cardiac effects following acute myelitis. For myelitis, the patient receives MPS and IVIG, sinus bradycardia, and AV block. Patient needed intermittent atropine. And patient outcome was completely recovered. Now the summary of the cases which were handled here in literature. For myelitis perspective, every patient from each patient received MPS. One patient received IVIG, also received IVIG along with methylprednisolone. Another patient received plasmapheresis along with methylprednisolone. One patient received all the three modalities of treatment: MPS, IVIG, as well as plasmapheresis, and that patient needed permanent pacemaker for bradycardia. For cardiac perspective, permanent pacemaker needed by one patient. Atropine followed by dopamine infusion in one patient, or only atropine in one patient, and one patient didn't need any intervention. However, in our case, our patient needed MPS and norepinephrine for around 10 days. Then only we can put it off. Currently, she is on a lowering dose of steroid. That is, our patient is more serious and severe. Although our patient is showing bradycardia improves, but her hypotension was so intractable, she needed norepinephrine for longer duration. Again, the one question remains unsolved: that what is the reason of bradycardia in our patient? Her serum electrolytes normal, third position normal, ECG showing just bradycardia, no conduction abnormality, no RR variation, PDUCO normal. She had been didn't administered any drug which is associated with sinus dysfunction. We again search in literature. In acute myelitis, we didn't get any literature, but in a spinal cord injury, especially due to traumatic injuries, there are lots of literature, and they are showing anatomical transition of the spinal cord at cervical level that's leading to transition of the sympathetic trunk, and this anatomical transaction leading to more pronounced parasympathetic activity. The similar phenomenon of anatomical transaction is just showing in our patient in functional transaction at central control level, and that central control over lateral cord, it may be like a spinal shock in that way that she has so much hypotonic, we are getting that a severe acute transaction that may be disruption of the upper floor, that is sudden withdrawal of vasomotor tone, and this regulates the leading to dysregulation of the cardiovascular system, and this patient needed norepinephrine for longer duration. Now I am requesting Professor Jayanti Kalita Madam for further discussion. Just. This summary. Just.
Hello, good evening, ladies and gentlemen. It's a great pleasure to see you all again in this forum. And most of the things has been discussed by my resident and our faculties and fellows. I just will summarize some of it, which may be a little repetitive. Is it moving? Okay, is the slides are moving? Okay. Now that why we thought about West Nile myelitis. Already Dr. Prakash told that it is a priming effect. We have seen one or two patients earlier, and that has led to think about when the other viral profiles were negative. The evidence of parainfectious myelitis was fever immediately followed by paraparesis. There was no intervening period between fever and the neurological deficit. And she became bedridden within hours. That has ruled out the possibility of demyelinating disease. Anterior spinal artery thrombosis, again already discussed that although she had flaccid quadriparesis with evidence of slight hemorrhagic changes, and EMG is showing extensive fibrillation, but presence of posterior column involvement and a horizontal sensory level rules out the possibility of interspinal artery thrombosis. The viral etiology may be of herpes group, EB virus, influenza, echo, HIV, and hepatitis A. And flaviviruses like Japanese encephalitis also can result into encephalomyelitis. Although in Japanese encephalitis, thalamic involvement is very common, but somehow when you did the somatosensory evoked potential, majority of the patient, almost all, in fact, they have normal SCP. And in Japanese encephalitis, we get focal reflex loss rather than generalized areflexia. In West Nile encephalitis, of course, there may be starting from transverse myelitis to enterohorn cell disease, there may be extensive myelitis as well. And the myelitis may be at times more severe than the encephalitis. Zika can have similar presentation, enterohorn cell involvement. And dengue and scrap typhus, scrap typhus is a bacteria, but dengue and scrap typhus can produce viral myositis. Now, how to differentiate various, do the all para-infectious or infectious myelitis look same or it is different? If you see herpes group of viruses like herpes zoster, herpes simplex encephalitis, CMV and EB virus, they usually present with radiculomyelitis. That means patient will have radicular pain and along with that patient will have myelitis. And diagnosis can be confirmed by PCR, CSF, if within 1 week, or if it is more than 1 week, it should be IgM ELIJA is better. For herpes group, azacitidine is a drug of choice for both simplex as well as zoster. And for CMV, ganciclovir is used, but with variable efficacy. Poliovirus, it is the acute flaccid weakness, only enterohorn cell involvement. There will not be any sensory deficit. Diagnostic modalities are PCR, either stool or CSF, and treatment is supportive. Flaviviruses, JE, West Nile, Zika, they can produce acute flaccid paraparesis or quadriparesis. CSF, PCR within 1 week or IgM ELIJA later on may clinch the diagnosis, and treatment is supportive. HIV, HTLV is unlikely because they present with spastic paraparesis and usually chronic in onset. And amongst the etiology of bacterial, that is mycoplasma, syphilis, neuroborreliosis, and tuberculosis, they can also present acute flaccid quadriparesis. Syphilis have predominant sensory loss with pain, tabes dorsalis. Mycoplasma may have ATM-like presentation, and tuberculosis rarely can present acute flaccid myelitis. Again, the diagnostic in mycoplasma, respiratory examination will give rise to diagnosis. Syphilis, either serum or CSF, BDRL, or Treponema pallidum immobilization test. For neuroborreliosis, Lyme serology and CCC PCR in the CSF. And for Lyme's, it is the neuroborreliosis, it is the treatment of choice is ceftriaxone. For syphilis, penicillin, and mycoplasma, it is the supportive. Tuberculosis, of course, it is ATT. And neurocysticercosis and other parasitic infection may have myeloradiculopathy, or there may be intraspinal granuloma presenting like acute transverse myelopathy. Serology and can diagnose the NCC, CSF antibody, and for schistosomiasis, rectal biopsy can give rise to the diagnosis. Treatment of choice is albendazole and praziquantel with steroid. And these are different fungal infection also like coccidioidomycosis, histoplasmosis, cryptococcosis. They can also sometimes present acute flaccid paraparesis. And again, the diagnosis either PCR or ELIJA. And here the antifungal treatment is the drug of choice. Therefore, it is very important to know what is the underlying infections for which so that the treatment can be tailored. And these are the topographic location of the various infection. If you see transverse myelitis, mostly para-infectious or neuroborreliosis, they can produce the whole of the spinal cord. Enterohorn cell are involved with poliovirus and other enteroviruses, and flaviviruses like Zika, JE, and even West Nile. Intramedullary lesions can be found in tuberculosis, endemic mycosis, and schistosomiasis. Dorsal column are usually involved with syphilis. Dorsal root ganglion involved by herpes virus infection, specifically herpes zoster, and dorsal and lateral column by H. And nerve roots are affected by glioblastoma. And these are the report, actually earlier studies we have done in Japanese encephalitis. This is a patient who had severe movement disorder and he had severe wasting of the anterior compartment. We thought, is it a diffuse atrophy? But to our surprise, when we did the EMG, there are full of fibrillation and sharp wave, suggesting that he had enterohorn cell involvement. Later on, we have done spinal MEP, EMG, and nerve connection studies in 12 patients, and 7 had involvement of the enterohorn cell. These patients during the acute stage if we examine them, there may be focal reflex loss. And very soon the reflex loss will be dominated by hyperreflexia because of pyramidal tract is more predominantly involved in Japanese encephalitis. And if we do the wasted muscle EMG after 10 days, then there are fibrillation. So therefore, it is said that Japanese encephalitis is a encephalomyelitis rather than encephalitis alone. And in the initial part, we were very scared to talk about the enterohonchal involvement, and to our surprise, in 94, this is the patient who had enterohonchal involvement in the cervical region, and he had biceps and supinatory absent. And when we read about the earlier studies, Zimmerman et al. In 1946, as early as that, he reported spinal cord involvement like polio-like illness. There is there are damage to the pyramidal cell, enterohonchal, and giving rise to polio, like looking like polio. The histopathological pictures were looking like polio. This was the earlier patient what we saw. This patient had acute transverse myelitis. Along with that, he had pontine involvement and there is spinal cord involvement. And that fellow, the cranial portion, he improved very quickly, but the major deficit was spinal involvement, and he had a major sequelae. And in that case, we have reported a review of literature of the spinal involvement in Western encephalitis. And these are the various case reports in different studies from different parts of the world. And to summarize, there were so far till 2020, 57 patients with Western myelitis, 52 were followed up, and 11 of those patients died. And remaining 41 patients had persistent deficit. That means if the patient is extensive spinal cord involvement, their outcome may not be as good as in other diseases. And cardiac arrhythmia, already Dr. Nagin and Prakash had told you that not only in Western encephalitis or myelitis, even with simple viral infection, Western fever, 4 patients had cardiac involvement, Western encephalitis, 7 out of 65, Western virus and meningitis, 2 out of 103. This is a study from Colorado. And here they have ruled, they did not include those patients with sinus bradycardia and tachycardia. They have included the patient with more serious form of arrhythmia. The 3rd degree heart block in 2 patients, atrial fibrillation in 9 patients, ventricular tachycardia in 1 patient, and torsion de pointes in 1. And this is another patient which has been reported by Azam et al. One can see initial ECG was showing QTC interval was 525. He had 34 bradycardia, patient had bradycardia and 1st degree atrioventricular block. And later on, the same patient, his QTC prolongation has disappeared and heart rate improved. So this is the way transiently, without any intervention, this patient improved. And severe arrhythmia has been reported in 3 patients, and all were above the age of 65 years, males. One had asystole and he died, and autopsy revealed cardiac involvement. The other patient had severe bradycardia, idioventricular rhythm, and he needed pacemaker implantation, and he survived. And another patient, bradycardia with QTC prolongation, he had increased troponin and he survived. But our patient did not have troponin, high troponin or CKMB. So therefore, primary cardiac involvement in our patient is unlikely because of associated autonomic dysfunction, and he had spinal cord involvement as well. And this is the autopsy series of West Nile infection. What they have found that in the dorsal root ganglia, the sympathetic neurons are severely damaged. These are the degranulation, the total damage of the sympathetic neurons giving rise to eosinophilic bodies. So that may be the cause in our patient why he had severe bradycardia, she had severe bradycardia and hypotension. Now coming to the hemorrhagic acute transverse myelitis, there is a possibility that this patient had mild hemorrhagic changes. And hemorrhagic myelitis, acute transverse myelitis is extremely rare because of, not because it may occur in vascular problem, but in non-vascular disease, it is extremely rare. We have earlier reported one idiopathic acute transverse myelitis with spinal cord hemorrhagic changes who had postural hypotension. And it was difficult to rehabilitate him because moment he sits up, he had severe syncope. The other 8 patients, 1 had post-vaccination, 3 had SLE, 1 had ITP, and 3 had idiopathic region. And 2 out of 8 were able to walk, and remaining 6 patients had severe disability. Management issues in this patient already discussed. For respiratory failure, she was intubated, mechanically ventilated. Now she is having little effort of her own. Hopefully we'll be able to win her off. Myelitis, methylprednisolone. In West Nile, people have tried IVIG. However, we did not given her because now she is stabilizing. And hypotension and bradycardia, one can use anticholinergic, norepinephrine, methylprednisolone, prednisolone, and glycopyrrolate. The indication of cholinergic overactivity is diarrhea and her excessive secretion at the same time bradycardia. So that suggests that she had excessive cholinergic system activity. Now, how to prognosticate acute transverse myelitis? If their patient attend and ask how we can prognosticate. This is the study we have done around 1998. And prognostic predictors of acute transverse myelitis, proclinical and neurophysiological means. What we found, if the patient is having flaccid weakness, areflexic, with EMG revealing fibrillations and shockwaves, then we can classify poor prognosis at 6 months in 90% patient. By adding CMCT and CSCT, or CMCT or CSCT both, doesn't give any additional help. And only CMCT and CSCT one can classify 80% situations. And therefore, if the patient is having severe weakness, areflexia, wasting, and EMG revealed denervation, then they have likely to have poor outcome at the end of 6 months. To conclude, parainfectious ATM is prevalent in tropical country. Hemorrhagic myelitis rules out primary demyelinating diseases. Anterior-hornsel involvement in ATM suggests poor outcome. Cardiac rhythm abnormality may be due to cardiac myositis or may be due to sympathetic ganglia involvement. Bradycardia and hypotension suggest disproportionate damage to sympathetic pathway. Thank you so much. Thank you. Hello.
All of you would agree, Madam,
Yes.
for an excellent presentation.
Thank you
And
so much.
you have taken us through excellent area, which is often undiscussed and unfocused for the residents. And it will be a real great lesson for all the postgraduates involved in neurointensive care in looking for the involvement of the cardiac in cases of transverse myelitis. Wonderful presentation. My congratulations to the entire SGPGI team. And the subject is open for discussion. I'll just check up whether there's any open questions. There are a few.
Questions, I already answered them.
So you answered by typing the answer. Okay, madam.
Yes.
Madam, okay, one minute. I'll just have.
You can ask if anybody wants to ask questions, no problem.
Yeah, I'll just. Super presentation by respected madam. How to explain medullary infarct diffusion can be viral induced
It's not
vascular.
probably infarct. It is because of your acute transverse myelitis during the acute stage. There may be diffusion restriction, because diffusion restriction only denotes cytotoxic edema. So therefore, if there is necrotizing myelitis, so in that situation, we may get diffusion restriction the way we get in herpes simplex encephalitis or in other encephalitis.
Professor Venkama has asked, how do you explain 1,000 cells in CSF in viral infection?
Yes, that's right. In fact, in first CSF at the periphery, it was 1,000 cells with 91% polymorph. Definitely, we had a possibility that are we dealing with epidural abscess or spinal abscess. But her peripheral blood counts were normal, and fever without antibiotic within 2 days it is subsided. Sometimes in viral, although viral diseases do not produce so much of cell count, but rarely one may get pyogenic type of response. Even in tuberculous meningitis, we may get pyogenic type of response. Probably it is unusual, but probably we may, this case at least we got 1,000 count, know what to do. But subsequent count is 500, so probably 500. Oh, okay.
Have you seen a COVID myelitis?
Yes, COVID myelitis, yes, COVID myelitis in this case probably is negative. We have resident is saying that they have done it and it is negative. We have seen.
What are your observations in COVID myelitis?
COVID myelitis, actually, I was not directly involved except 2 times ICU duty. We got one patient who was looking like paraparesis, but he had more of a muscle disease, extensive myositis that we presented earlier neurophysiology workshop. So he had limbic encephalitis, and later on his encephalitis disappeared, but he was unable to walk the foot drop like presentation. And when he did the EMG, his nerve conductions were normal and EMG was showing fibrillation and myopathetic potential. Myelitis, I have not seen any patient. GB-like presentation, myositis is more common. GB-like presentation may be there following the COVID infections. And COVID can also produce para-infectious probably myelitis, probably, but I have not got any patient.
In fact, for the sake of postgraduates, I just want to add that we had the good fortune of treating around 80,000 COVID patients in all these three together.
Okay.
And we have seen both COVID, BBS-like syndrome in COVID, as Madam said, but we have seen few cases of para-infectious myelitis associated with the acute COVID. And not only that, post-COVID vaccination also. We have
Yes.
seen a couple of post-vaccinal myelitis. Also, we have seen, and they turned out to be, one of them turned out to be an hemorrhagic transverse myelitis post-vaccinal.
Okay.
I really don't know, because the vaccine used was the Covishield, which has another, that the viral vector-based vaccine. So whether it was we really don't know whether what was the causative, and that is the only case which we documented.
Yes, there is more and more cases are coming out, even with mRNA vaccine, or even the different type of COVID vaccine, including myocarditis. So these are the probably I don't know, means, and anybody.
On behalf of all the residents, and I really thank you for a wonderful case, and
It's a pleasure.
and all the residents are really blessed to listen from the I would say Madam is the authority on neurophysiology in the country, and we are grateful that you spared your time and then joined us in this wonderful discussion. And over to Professor Sudhir Shah for his comments.
Thank you for the comments, lovely comments. But okay, thank you.
Dr. Kalita, Madam, this was indeed a wonderful presentation, and it is very surprising and interesting and exciting to see that all three aspects: neurophysiology, the critical care neurology, the tropical neurology, all the subjects which you have mastered already, they are all in one case. And the way the case was discussed and different aspects were highlighted and each symptoms were correlated, I think this is one of the most interesting cases in the whole webinar series. And I really compliment the whole team for doing such a great work of the case and such a nice explanation. It was really an enlightening case, and we are all very much thankful to you for the nice elaboration. As regards the CSF cells, Madam, they were all lymphocytes, or they were, what was the proportion?
Initially, sir, it was 91% polymorph. We were also quite intrigued to see that. But somehow, probably in acute viral infection, sometimes we may get polymorphonuclear leukocytosis rarely, but it is not commonly we see. But during that time, the patient did not have peripheral blood leukocytosis. That doesn't go hand in hand with pyogenic infections.
I agree with you. And sometimes in polio also, in those days, when polio was rampant, we have noted and we have seen the reports of lots of cells up to 1,000 or so, and some of the cases have mentioned even the polymorphonuclear. So West Nile has also antigen cell involvement, and I think this was a very important case. What surprise, and that has been proved by PCR, it is West Nile. So I'm sure this would add to the world literature. So it's that level. And I'm sure all the residents would be much benefited with today's case and the discussion. Thank you, ma'am, and looking forward to having you again in after a couple of more cases. You will be again requested to come up with some fantastic case like this.
Thank you, sir.
Thank you, sir. Thank you, ma'am. Thank you so much.
It is a great opportunity for my team to at least present this case, and we also enjoyed managing this patient and difficulties we faced. It was a very difficult case to manage, actually, bradycardia, hypotension, diarrhea. It was very difficult, but
frankly, we have been pursuing with your... Frankly, we were pursuing with SDPGI team for quite, I think for last 6-8 months to present the case, and we are lucky that today you could do that. Yes, sir. Go ahead, Dr. Lakshmi. What do
Actually,
you
they
say?
are not asking me. Lakshmi, he is stepping the wrong place. So
No,
the moment he asked me, I immediately agreed.
I
because
know,
it-
madam, I didn't want to bypass the hierarchy. You know, most of the
that's right.
institutes are hierarchy based. So I thought once it is not done, then I know. I mean, I thought it's
Because
please apologies for me. Apologies from my side.
no
I'm
problem.
so
Because of
sorry
being a
to
teacher,
have made
Yes,
this
sir.
comment, ma'am,
Being-
but I
Listen,
thought.
no, sir, no problem. Because it is being a teacher, probably it is very difficult to refuse not to have an academic session.
All
is-
premier institutes have already contributed. It's only 1 or 2 issues like yours were pending. That's why we were pursuing very hardly. So that was the point. Thank you, ma'am. Thank you.
Thank
ma'am.
you so much. Thank you. Thank you.
Dr. Lakshmi wanted to say something to sum up.
Nothing, sir. Sir, and it's a wonderful presentation, sir. We can hand over to the.
Okay.
Thank
Thank
you.
you, sir.
Mr. Chadda, please go ahead.
Thank you, sir. Thank you very much. And today is really great day as we are at the end of 32nd session of Secret of Neurology. I, Arun Chadda, Affiliate Vice President, on behalf of Intas Pharmaceutical, would like to thank and propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence. In the last 32 months, it's audience like you that make the presentation awesome. Thank you very much for your unwavering attention throughout this presentation. And I would like to thank our Honorable Course Director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DND students. We are very thankful to young neurologist Dr. Rupali Mahajan for presenting the excellent and unique case. Further to this, I would like to thank Dr. Nagendra Babu sir, Dr. S. Trivedi ma'am, Dr. P.C. Pandey sir for presenting the differential diagnosis and radiological aspects. And thanks to Dr. Jayanti Kalita ma'am, the professor and head of Department of Neurology, SGPGI Lucknow, for sharing his experience in this case and providing the important learning point and providing her experience in this case of the unique case of this. And the entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for your gracious presence and it's being clear with all of you today. Thank you all for your patience and we will meet again on 31st of March,
Okay.
2023 with yet another case. Till then,
Thank you.
stay safe and take care. Thank you.
Thank you. Thank you, sir. Good night.
Thank you, ma'am.
Thank you.
Thank you very
Good,
much.
good night.
Thank you. Thank you. Good night, ma'am.
Good night.
Thank you. Support system.
Prashant Bhai.